He's the first physician on the East Coast certified as a diplomat of the American Academy of Cannabinoid Medicine. He practices in Hollowell at Maine Integrated Healthcare, as well as in Falmouth and Integrate Health LLC. Please give a warm round of applause for Dr. Sulak.
Well, good morning, everyone. My name is Dustin Sulak. As mentioned, I'm an osteopathic general practitioner with an emphasis in integrative medicine. And in my practice, I rely heavily on OMT and other integrative interventions that are natural, safe, and effective. And it's really my honor to be here this morning to be able to present to you some exciting information about medical cannabis and cannabinoid physiology. I'd like to thank you all who are here for waking up early to make it to breakfast and to this lecture. I really appreciate your presence. Thank you. Now here's AT still. Man should study and use the drugs compounded in his own body. I have for a long time been interested in healing, how it works, how to stimulate it, what causes it to fail. And that journey took me into osteopathy, and I feel truly honored to be part of this man's lineage. Following Dr. Still's suggestions, I'd like to introduce you to a topic that acknowledges the human body's innate healing wisdom and present you with some therapeutic interventions that work with the healing system. Here's an overview of what I'll be covering today. The endocannabinoid system, some background and some physiology, a brief history of medical cannabis and its use, cannabinoids that come from the cannabis plant as well as synthetic cannabinoids, and then some selected topics in cannabis therapeutics, including neuroprotection, pain, inflammatory bowel disease, glaucoma, and cancer. We'll wrap up with the safety of cannabis, some cautions and contraindications, legal considerations for using cannabis here in Maine, and finally some patient education. I've included a few more slides than we'll have time to cover today, and that's because I wanted to get them into your syllabus and make that information available to you. If I skip over something quickly and you'd like to hear about it, we might have some time at the end and I can come back. So why didn't we learn about the cannabinoid system in school? When I first learned about the cannabinoid system, I realized that it's a primary component of the physiology of healing. And I was amazed that this was omitted from my expensive medical education. If we look here at a PubMed search for the term endocannabinoid, we see that in 1993 there were 10 citations, and in 2012 over 5,000. So that's an average of more than one scientific paper published every other day for the last 19 years. If you take out endo and just search for cannabinoid, you'll get 20,000 plus results. So despite this huge body of scientific evidence and this physiologic system that's truly integral to our healing, most of us know little about it. And that's why I'm really excited to inform you on this topic today. I think it's really crucial knowledge for anyone in the healthcare field to understand. Imagine if we had never learned about some other major physiologic system like the autonomic nervous system, or if we had never heard of acetylcholine before. I think that's analogous to how important and central this information is to the healing process. A summary of all of those studies, which I have not read all of them, is that the endocannabinoid synthesis is an adaptive response to cellular stress aimed at reestablishing cell homeostasis. So this is one of the very basic homeostatic mechanisms in our physiology. If we look at the endocannabinoid system, we can see that its discovery and research has lagged other physiologic systems, such as the endorphin system. And this is primarily because cannabinoids are fat-soluble. That makes laboratory research very challenging. And just up until recently, we've developed techniques that allow us to really look closer at these compounds. So the first endogenous cannabinoids were discovered in 1992. Here's the cannabinoid receptor. We have 2 cannabinoid receptors in the body that have been discovered, and I think there will likely be a third that we know about at some point. This, as you can tell, passes the cell membrane 7 times, like any classic G protein receptor. What's interesting is that this is one of the most prevalent and widespread G protein receptors in the entire human body. The cannabinoid receptor evolved around 600 million years ago. When we look at very primitive animals like the nematode and the sea squirt, we find a CB1 receptor in them that's almost exactly the same as what we see in humans, meaning it's highly conserved, and it is highly conserved because it's so central to the physiology of healing, of helping animal life maintain homeostasis. Insects do not have cannabinoid receptors. Now, the cannabinoid receptor, if we look at the brain, is the most common G protein receptor found in the central nervous system. It has its highest densities in the hippocampus, the cerebral cortex, the cerebellum, amygdaloid nucleus, periaqueductal gray. And if we look at the areas of the brain where we find the most receptors, they correlate with the effects of cannabinoids, such as changes in short-term memory, cognition, mood and emotion, motor function, nociception. And what's interesting and very nice therapeutically about cannabinoids is that there's virtually no cannabinoid receptors in the brainstem, which is why there's no such thing as a lethal overdose of cannabinoids. Now, outside of the brain, as I mentioned, this receptor is believed to be one of the most dense endogenous G protein receptors in the entire body. And that explains why cannabinoids have such a broad range of therapeutic effects. So we'll take a little look at it. A lot of this information is just emerging, and I feel when we study the endocannabinoid system like we're just kind of looking at the tip of the iceberg, but we do know a lot. For example, the CB1 receptor, we find it in certain tissues like the central nervous system, reproductive tissues, connective tissues, some of our organs. The CB2 receptor is found more in our immune system cells and also in some of our organs. But what's interesting is that these receptors get expressed differently under different physiologic conditions. For example, we don't really see CB2 receptors in the nervous system, but we do see them after a trauma to the central nervous system. The body will upregulate that. If you look at this, I find it very interesting that endocannabinoids are found at the intersection amongst the body's various different systems, allowing for communication and coordination between different cell types. Here's an example. At the site of an injury, cannabinoids can be found decreasing the release of activators and sensitizers from the injured tissue itself. Cannabinoids will also be found stabilizing the nerves to prevent excessive pain signaling to the brain. And they'll also be found stabilizing the local immune cells to prevent an over excess of inflammation. So these are 3 different mechanisms of action from 3 different cell types, all for a single purpose, which is to minimize pain and damage caused by an injury. We see the cannabinoid system working as a means for communication amongst different cell types all over the body. And this may give an explanation of the connection, one physiologic explanation of the body-mind-spirit interface. Here are 2 endogenous cannabinoids, anandamide, named after the Sanskrit word ananda or bliss, discovered in '92, and then 2-arachidanylglycerol or 2-AG, discovered in '95. These are very interesting compounds. They're not stored in cells. They're actually synthesized on demand from cell membrane precursors, omega-6 precursors, and then they're immediately released to act as, in the nervous system, they actually act as retrograde messengers across the synapse, and elsewhere in the body, they act as autocrine and paracrine mediators. They're homeostatically controlled by enzyme hydrolysis. FAAH degrades them for the most part, which is a common enzyme. And so now we're going to get into a little bit of the nuts and bolts of how the cannabinoid system works in the nervous system. This is really exciting and new information, or new to most of us. When I first learned about it, I was really intrigued. We see that most of our concepts of how the synapse works is that we've got these neurotransmitters stored in vesicles in the presynaptic nerve terminal, and that when something happens in that terminal, the neurotransmitters are released, the vesicle opens, they float across the synapse, make some change in the postsynaptic cell. Cannabinoids actually go backwards across the synapse. They're synthesized on demand from the postsynaptic cell membrane. They go backwards across the synapse and they make some change in the presynaptic cell. So let's take a little bit of a closer look and find out what they're doing. So here's a bit of a schematic. We see an action potential coming down in the presynaptic terminal. It opens up some ion channels, calcium floats in. This is an example of a glutaminergic neuron here. So we get the glutamate vessels opening and glutamate traveling across the synapse, making some postsynaptic change. When that change becomes strong enough in the postsynaptic cell, then we see calcium channel open and some depolarization event occurs. That's very common, we're all familiar with that. When that depolarization gets to a certain point, it triggers the synthesis of endocannabinoids, like this in this example 2-AG on the postsynaptic cell. The endocannabinoids flow backwards or across the synapse, stimulate the CB1 receptor on the presynaptic terminal. That closes the calcium channels and prevents further release of glutamate. So it's kind of like a negative feedback mechanism, tells the presynaptic cell when it's time to chill out. If we look at a GABAergic neuron, the same process happens. So this is called depolarization-induced suppression of inhibition. The previous slide was depolarization-induced suppression of excitation. Cannabinoids can modulate excitation and inhibition. And we see an effect like this all over the body, again, because this is a homeostatic system. If there's too much, it makes a little less. If there's too little, it makes a little bit more. So that's cannabinoids in the central nervous system. We'll get back to a little more cannabinoid physiology a little bit later, but I want to move on to talk about cannabis. So this is the plant, Cannabis sativa. If you look at the picture on the top, this is the herbal variety. The female flower is what produces the medicine of cannabis. It's actually the term sinsemilla, which is often used, literally means without seed, and that makes for a more potent medicine. So the active constituents are found in the oily substances, these resin glands called trichromes. They're present in the female reproductive structures, and their purpose is to attract pollen granules and have them stick to the female plant. When there is no fertilization, the plant keeps making more and more of this oil in hopes of getting fertilized, so that increases the potency of the herb. In the plant itself, cannabinoids also have protective functions. They're antioxidants, antimicrobial, and anti-pest properties. If we look at the bottom picture, this is the same species, just a different variety, hemp. The flowers of hemp have almost no THC, very low cannabinoid content, but they are very good for textiles, fiberboard, paper. You can build all sorts of things out of hemp fiber. It's one of the longest and strongest known to man. The seed is high quality for food, oil, synthetics, lots of industrial uses. Here's a partial list of health conditions that I've compiled that have at least some preclinical or clinical evidence that cannabinoids can affect these conditions in some positive way. It's kind of amazing and hard to believe that one therapeutic substance or one group of substances could have such a widespread effect. And when I first started reading all this and hearing about it, I was skeptical, like I think all of you should be, that is this some kind of snake oil cure-all? Can this really help everything from infectious to inflammatory to nervous system to all these different disorders? And the answer is that it can, and that's because it's interacting with our endogenous cannabinoid system. So that's why one herb can help so many different systems, so many different conditions. We're actually hardwired to respond to this type of medicine. Quick history. Cannabis evolved in Central Asia approximately 34 million years ago. So we talk about the cannabinoid receptor 600 million years ago. This plant came along about 34 million years ago. ago. And it was used indigenously by those cultures, Ayurveda, Tibetan medicine, Chinese medicine. We have some evidence that the Chinese were writing about it around 5,000 years ago. Of medicine, Sir William Osler commented that cannabis indica is probably the most satisfactory remedy for migraine. In the late 19th and early 20th century, cannabis remedies were quite popular and certainly part of every medical kit. They were manufactured by some of the big pharmaceutical companies back then. Here's a picture of a cannabis tincture. They were used for childbirth, for labor pains, for infant colic. There were many topical uses for bunions, warts, and other inflammatory skin conditions. So this was really prevalent until cannabis prohibition came along. Here's the three most common phytocannabinoids in the middle. You see delta-9 THC and its molecular structure, which if you remember the slide I showed before of the endogenous cannabinoids, the molecular structure is actually quite different, but they fit into the same receptors, so it works. On the top we have the non-psychoactive cannabinoid cannabidiol, which I'll speak more about shortly, and on the bottom cannabinol. So many of the phytocannabinoids are non-psychotropic, yet very therapeutic. And here's a chart of some of those. We think about cannabis therapeutics as this thing that has a psychoactive effect, but that's not necessarily true. CBD's been getting a ton of attention here, and here are some of its observed effects with proposed mechanisms. I'll read them to you since it's quite small. Anxiolytic, antipsychotic, anti-epileptic, neuroprotective, antispasmodic, anti-ischemic, antibacterial, intestinal, antiprokinetic, analgesic, bone stimulant, immunosuppressive, anti-inflammatory. These non-psychoactive cannabinoids are gaining a lot of interest. What's happened in the underground market for the last few decades is that cannabis has been bred to be psychoactive because that's what sells the most to people who are looking to get high. So a lot of these strains of cannabis that have non-psychoactive medical properties have actually been selected against. And so what we're left with is cannabis that is very psychoactive. But there's been a resurgence of breeders who are growing strains of cannabis specifically for therapeutic properties that aren't necessarily psychoactive at all. And we're starting to see this in Maine. It's been happening in California for a while. We're just starting to see the emergence of some of these non-psychoactive strains of cannabis, or I should say minimally psychoactive, and their therapeutic properties are really impressive. There's also synthetic cannabinoids that some of you may be familiar with. This was the only time I ever heard the word cannabinoid mentioned in medical school in a pharmacology class. Dronabinol, which is just synthetic THC, was approved in '86. It's now Schedule 3. Nabilone, also known as Sesamet, is a THC analog. Both are indicated for chemotherapy-induced nausea and vomiting. So even if you're from a state that doesn't have medical marijuana legal yet, there are some options for cannabinoid therapeutics. Off-label use of these medications in the ways that we're describing today can also be effective. Here's some synthetic cannabinoids, some with ultra potency. These are very good for research. You can see, for example, HU210 down at the bottom is a very strong CB1 agonist, 600 times the potency of THC. So some of you may have heard of this stuff called Spice or K2 that's being sold over the counter at some head shops and things. It's an herb that looks like cannabis, and then they spray some of these synthetic cannabinoids on them. There's been articles that these are showing up in emergency departments. The synthetic cannabinoids have much worse side effect profile, and people are much more likely to have an adverse reaction than the herbal cannabis. Of course, cannabis prohibition makes these synthetic cannabinoid lookalikes appealing to young people in states where, in the U.S. where it's prohibited. There's other phytochemicals that are therapeutically active in cannabis outside the cannabinoids, such as the terpenoids and the flavonoids. Some have therapeutic properties that are effective in microgram doses, so it can be thought of like an aromatherapy, but they're actually quite potent. Something that's really interesting, just starting to be studied, is raw cannabinoids. So almost all of our research on cannabinoids have been exposed to heat. When cannabinoids are raw, they have a carboxylic acid group, which which makes them more water soluble. They don't fit into the CB1 receptor, so they're non-psychoactive, but they do have seemingly some anti-inflammatory and antioxidant properties. So ideas like juicing cannabis and drinking the raw juice is starting to become popular in California. So I just want to present an example of herbal synergism. Whenever looking at plant extracts, we tend to find multiple compounds that work together. So CBD, this is one example, normally present in insignificant concentrations in cannabis, antagonizes the undesirable effects of THC, such as intoxication, sedation, tachycardia, while contributing to the analgesic, antiemetic, and anti-carcinogenic properties. So again, finding strains of cannabis that are high in CBD is becoming really interesting, sought after in the cannabis field. I was recently at a convention where a study was presented that showed the anti-tumor effects of THC and CBD were much greater than THC alone in glioblastoma. So I just want to kind of present this picture to you because some people give me the argument, well, we can prescribe Marinol, why do we need medical marijuana? And I just want to remind you there's a big difference between using a purified pharmaceutical substance that has unidirectional physiologic effects versus using a whole plant that is a complex homeostatic modulator with multiple compounds that work together. A little on safety. National Academy of Sciences Institute of Medicine, 1999, stated in a very large report that except for the harms associated with smoking, the adverse effects of marijuana are within the range tolerated for other medications, and that there's no conclusive evidence that marijuana causes cancer in humans, including cancers usually related to tobacco use. So a little more on that. A study from 2006 by a pulmonologist who was initially somewhat against cannabis. This was over 1,000 cancer cases and over 1,000 cancer-free controls matched. And this study found no positive association for cannabis use with upper respiratory tract and lung cancers. And if you look at the odds ratio down here, you can see, slight increase for oral cancer, and actually somewhat of a significant, or close to significant decrease for lung cancer, 0.62 odds ratio. We know that there's carcinogens in cannabis smoke. So definitely cannabis users who are smoking it are exposing their respiratory tract to carcinogens, but there's no more cancers, and that probably has something to do with the anti-cancer properties of these cannabinoids. A little on marijuana addiction. This was a study that looked at the abstinence effects of cannabis, and it showed that there certainly are abstinence effects that are dependable. Sure, I've got a question in the back.
It's a bit unfair, it seems, when you're comparing someone who's throwing down 2 packs of cigarettes, 40 cigarettes a day, maybe 1 joint a day, to do a study that's going to be showing somebody's effect on cancer, which we know is throughout the body's response to overgrowth due to damage. If you do 1 joint a day as opposed to 40 cigarettes.
Sure, it's a great point. For those of you who didn't hear, it was a comparison in the dosage, where if you look at tobacco smokers, they're generally using a pack a day, maybe 20 cigarettes, maybe up to 40. Cannabis users are using significantly less. In that study that I had just presented, tobacco use was part of the control that they looked at in comparing the 2 groups. So certainly, I think if someone was potentially smoking 20 joints a day or 40 joints a day, they might have an increased risk of cancer. Maybe not. We don't know because no one really uses it in that high of a dose. Anyways, the withdrawal effects from cannabis that are dependable are pretty mild. They're similar in effect and magnitude to those observed in nicotine withdrawal. Clinically, I've had certainly many patients tell me that it's much easier to stop using cannabis than tobacco, but things like decreased appetite, difficulty sleeping, weight loss, irritability, restlessness, and so forth. Some cautions and contraindications around cannabis use. Personal or family history of severe mental illness. is something to really look out for. And usually younger patients have a higher likelihood of having an adverse psychiatric reaction to cannabis. Pregnancy, that's disputed, but of course until we really know the effects of cannabis, we want to avoid using it in pregnancy. However, if you're looking at a risk-benefit comparison of cannabis versus certain other pharmaceuticals that someone who's pregnant that's really sick might need, cannabis still might be a safer choice. Concurrent use of stimulants and anticholinergics seem to exacerbate the negative side effects of cannabis, and so I'd use caution in combining it with those. It's not a contraindication, but it's something to monitor closely. And immunosuppressed patients, which is a pretty big topic because a lot of people undergoing chemotherapy and for other reasons, if they're immunosuppressed, they really benefit from cannabis. But we have to be very careful about mold, especially aspergillus, growing on the herb itself and then causing respiratory infections. Now, once we start getting into these high CBD, low THC strains, I think the whole risk-benefit ratio of cannabis therapeutics is going to be changing a lot in these patients. Here's a look at a study from England and Wales that was trying to figure out the number needed to prevent schizophrenia. So if we stop this many people from using cannabis, we can prevent one case of schizophrenia. It used an adjusted odds ratio of 2.1 for heavy cannabis use and psychosis outcomes. So there is an association of increased psychosis in cannabis users. We don't know that it's causal, but what they found in the study that the number needed to prevent was 2,800 in the heaviest in the heavy use men, younger men. Here we can look at some of the studies. Actually, you might be able to read it in your syllabus, but you can see number needed to prevent didn't get much lower than 1,800, and you got in some age groups and genders got well above 10,000. So the concept of trying to stop people from using cannabis just to prevent these negative psychiatric outcomes is a very large number needed to prevent, not really applicable to our clinical situation. Just look out for those individual patients that are at high risk. CBD, as I mentioned a couple times already, has some antipsychotic properties, also anxiolytic and anti-inflammatory effects, which I think if we're taking an osteopathic approach to mental illness, we have to think about inflammation. A recent review that looked at preclinical and clinical evidence compared CBD with approved antipsychotics and suggested that it would be effective, safe, and well-tolerated treatment for schizophrenia. My early observations have confirmed that CBD is very useful in mental health conditions. People with anxiety and agoraphobia and other conditions with the CBD seem to be doing really well. Some of the side effects of cannabis, most of these side effects are more prevalent with initial use, and then with recurrent use they diminish. They can be ameliorated by adjusting the dosage, the strain, and the delivery system. So I think when people are left to use cannabis on their own with trial and error, they don't really know how to use it, we're finding that they have more of these effects. When I talk to them and I start to help guide them into a healthy relationship with cannabis, these effects tend to go away. I'm going to show you how to do that with your patients at the end of this talk. But euphoria, some people, it's considered a side effect. In my clinic, I'm actually surprised by how often my patients tell me, when I ask them, are you getting any side effects from cannabis? They say, I'm getting high. How can I use this medicine without getting high? And it's like, well, do you mind getting high? Well, at night maybe it's okay, but I'd prefer to not have that during the day. Some people get an acute panic or paranoid reaction, typically with higher THC strains. An increased risk of psychotic symptoms, altered motivation. I don't want to say amotivation like it's been termed in some of the research, because it's really altered motivation. Someone might not want to go to work, but they tend to want to stay home and paint or sing or play music or do other things that they find rewarding and likely therapeutic. Impaired attention and memory and psychomotor performance, those aren't lasting effects, those are acute effects. Cannabis is a muscle relaxant. It has vasodilation effects, so there's usually responsive tachycardia, often very mild. It's usually in the first 15 minutes after use. Some people experience orthostasis. Dry mouth and other glandular secretions, including vaginal secretions, which dyspareunia after cannabis use is something I hear a lot about, and I just counsel patients to use lubrication. Increased appetite and weight gain, maybe. It does make food taste better. It does seem to increase appetite, but I have patients that lose weight using cannabis because they say they're more in touch with their food, they're getting more flavor and more pleasure out of every bite. And so they're eating less. It decreases intraocular pressure and causes vasodilation in the eyes. Those are the red eyes. Just to dispel some myths, of course, if we give rats enormous doses of THC, it has some immunosuppressive effects. Those are not observed in humans at normal dosages. Things like infertility, long-term cognitive effects, and causing cancer. None of that has been substantiated. Quick talk about driving. I counsel my patients to avoid driving when possible. Most of the studies that have looked at cannabis and driving show, driver simulation studies, that users of cannabis actually drive slower and more cautiously. They do have more variability in lane position and headway. But the real kicker here is that when someone's impaired on cannabis, they're aware of their own impairment and able to compensate. Whereas people driving on alcohol think they're fine and just step on the gas. So it makes a big difference. There was a question in the back of the room.
Yeah, do you know the mechanism for the decrease in intraocular pressure?
It's a great question. I'm going to do a couple slides on glaucoma. There's some proposed mechanisms that seem likely from animal research, but we don't know for sure yet. It's probably multiple mechanisms. So yes, some selected topics that I mentioned before. So I noticed the talk after mine today is on brain injury, and I just wanted to talk briefly one slide about neuroprotection. We talked about that suppression of excitation, where the cannabinoid receptor tells the presynaptic cell, stop releasing glutamate. Well, as many of you may know, in neurological injury, this excitatory cascade is very damaging. The cells die, they release all their contents, the glutamate that they release becomes toxic to the surrounding cells. Those cells die, they release their contents, and you get this chain effect. Cannabinoids prevent that glutamate excitotoxicity, so it actually limits infarct size post-stroke, and it prevents epileptic attacks or makes those attacks more mild. We also see that the anti-inflammatory, antioxidant, and antispasmodic properties slow the progression of multiple sclerosis. There was actually a study that just came out that showed that they did not slow the progression of multiple sclerosis, but there's some conflicting evidence there. There's also some early evidence that cannabinoids may benefit Huntington disease and ALS, and I've seen the effects on ALS firsthand, and it is really helpful. It seemed to stabilize a couple of my patients. Anandamide and 2-HG, so these are endocannabinoids, thwart Alzheimer's disease by blocking the microglial activation and preventing beta amyloid plaque formation. They seem to help rebalance the brain in Parkinson's disease. So a lot of neuroprotective properties. When we think of neuroprotection, we should really be thinking of the cannabinoid system. Oh, I guess I had two slides. Anandamide and 2-AG are endogenous neuroprotective agents. They're produced on demand by the nervous system in situations of both chemical and mechanical trauma. Delta-9 THC is neuroprotective. CBD is neuroprotective. So I'm mentioning CBD a lot. What's really interesting is we don't even know what receptors CBD works on. It seems to modulate the CB1 receptor's affinity for THC, but it's probably doing a lot more in places that we haven't found yet. And synthetic cannabinoid HU211, which also doesn't bind cannabinoid receptors, has been used in clinical trials against brain trauma. So let's talk about pain now. Pain is what I see mostly in my clinics, people who want to use cannabis as an adjunct or as a monotherapy for treating chronic pain. Just briefly, medical marijuana decreases pain, improves sleep and mood with modest side effects. A couple studies from Canada. These are actually old studies from the 70s, but a decent comparison. They looked at 120 milligrams of codeine, 20 milligrams of THC, found similar effects in compared to placebo in relieving pain. This was an interesting study from 2008 that looked at smoked cannabis and neuropathic pain. There's two lines here. These two lines are two different strengths of cannabis, 3.5% THC and 7.5% and 7% THC. Here's placebo. So what's interesting is we got a significant pain reduction. They smoked 2 puffs and 3 puffs, 4 puffs. Significant reduction in pain, when it comes to the side effects, you see that the people who used the higher THC cannabis felt more high, felt more stoned, and felt more impaired. So again, this draws attention to the fact that more THC isn't necessarily better therapeutically. Some of these low THC strains are actually quite useful. I want to talk about cannabinoid-opioid synergy because I know most of you are affected by chronic opioid use in patients. I think a lot of us feel limited by our therapeutic options when it comes to treating chronic pain. We know that opioids are great for acute pain, but all very problematic in chronic pain. Also very problematic when it comes to recreational use of the opioids and opioid dependence. Opioids and cannabinoids do share pharmacological effects, and there is crosstalk between these systems that shows a promise for novel treatments both against chronic pain and opioid addiction and abuse. Spinal administration of cannabinoids with morphine produces a greater than additive effect in anti-nociception. So we take THC at doses that are marginally active, so very small amounts of THC that don't really change the laboratory animal's threshold for pain, and we add that to animals treated with morphine. And we see the dose response curve for morphine shifts to the left 4 to 12-fold. That's really significant. The same thing happens the other way around when we add a little morphine to animals treated with THC. Also a significant shift to the left. What I'm getting at here is that cannabinoids and opioids work very well together in the treatment of pain. They're co-distributed in the areas of the brain that are controlling nociception, like the PAG, RAF nuclei, the central medial thalamic nuclei, and again, they have low densities in the brainstem. So while they potentiate opioids in the pain centers, they don't potentiate opioids in the brainstem, which actually increases the therapeutic index of opioids. They also cause upregulation of opioid receptor proteins in the spinal cord. This is almost too good to be true. I'll get your question at the end of the slide. They help retain efficacy in the combination of opioids and cannabinoids. Why don't we... there's a little extra information here. Sure, I'll get to your question. Someone had a question.
So let's say we have an opioid user, pain, chronic pain, heavy doses, never good enough because of the tolerance buildup and so forth. So then you add cannabinoids.
Sure.
Now you can take away some of the opioids. I doubt it.
Actually, I'll share with you what I've been seeing clinically. I've probably come across 200 patients that are chronic opioid users and that are cannabis naive. A lot of people come to me in my practice already using cannabinoids. I'll underestimate that within the first week of cannabis use, those chronic opioid users have cut their dose in half without anybody telling them to. The opioids actually just become too strong. So they decrease the opioids on their own, and over time, we're usually looking at a 75 to 80% decrease in opioids, followed by a stabilization of that dose, meaning they don't need to escalate their dose over time. If any of you have those outlying patients in your practice that have been stable on 5 milligrams of oxycodone 3 times a day for a decade, and you don't know why they're stable, but everyone else needs this escalating dose, ask them if they use cannabis. I'm almost certain they're going to say yes, because it really has this effect. I've seen it over and over again clinically. It's just a profound impact on the relationship these chronic pain patients have with their opioids.
Would this be a clue to diversion if somebody did not lower their dose?
Absolutely. Absolutely. I've never seen someone that's cannabis naive start cannabis and stay on the same dosage of opioids. And that's a really good point. I'll repeat it so anyone didn't hear. If they're cannabis naive and they start cannabis and they don't reduce their dosage, definitely look out for opioid diversion. This just talks about prolonging treatment efficacy with opioids because of the stabilization of those opioid receptors. And let's just get to the end of, so the conclusion is the administration of low doses of THC in conjunction with low doses of morphine seems to be an alternative regimen that reduces the need to escalate opioid dose while increasing opioid potency. This stuff is pretty well researched and published. I invite you to take a look at this review. That's really informative. There's been recently a small cannabinoid opioid synergy trial. This was just published at the end of 2011. 21 patients, chronic pain on sustained release opioids. Average was either 62 milligrams BID of oxycodone or morphine, 53 milligrams BID. The cannabis, this was done inpatient. The cannabis was supplied through a vaporizer, and it significantly decreased pain by 27% in these patients over a few days. The other thing I want to draw attention to is that cannabis helps with the global picture in the patient of chronic pain. It helps with sleep, depression, appetite, stress. I read the caption on this cartoon. The pain starts in my husband's lower back, then it travels up his spine into his neck, then it comes out his mouth and into my ears, and that's why I get these headaches. So, and we see this, and just going back to this study, it's a 27% reduction in pain, but really my chronic pain patients that use cannabinoids tell me that it's not so much that it's decreasing the intensity of pain. Yeah, it does that to some extent, but it changes the quality of the pain. It kind of puts it in the background, so I don't have to pay attention to it anymore. It's not right in my face all the time, and I can actually play with my kids, or I can actually function at work. It kind of changes the quality of the pain. It helps them sleep. It helps them laugh, be more positive. All these things that we know help the quality of life in someone with chronic pain. That's the last slide on chronic pain. Any other questions? Sure.
Better than gabapentin?
Sure, I think so. I don't have a lot of experience starting people on gabapentin, but I see a lot of patients who are already on it. But I invite you to explore this because my guess is that it's going to be better than anything else we've seen.
Is tincture the better choice for the physician?
Sure. The question was delivery systems, tincture, and I'm actually going to cover that coming right up. So let me get through this stuff here. Cannabis and inflammatory bowel disease. It's very popular with patients with inflammatory bowel disease. We know a lot of them are using it. A recent study showed 3 months treatment with inhaled cannabis improved quality of life measures, disease activity index, caused weight gain and rise in BMI. Multiple mechanisms here, so it's settling down the intestines, it's decreasing the inflammation, it's stimulating the appetite, it's helping them sleep, relieving stress. Cannabinoids in glaucoma. So cannabinoids do decrease intraocular pressure. It's about a 4 to 5 hour duration. There's not a lot of good human research on this. I wish if any of you are ophthalmologists that want to collaborate on getting some clinical evidence here, I'd be thrilled to have that. Topical cannabinoids don't seem to produce an effect in humans, at least in normotensive humans. It hasn't been tried in patients with glaucoma, but we know that beta blockers and cannabinoids do have additive effects. So the mechanisms of action, again, they're multiple. This is a very complex system, but we think it has something to do with in the anterior eye activation of the CB1 receptor that has some control over the aqueous humor dynamics. We know that it reduces autonomic input by decreasing norepinephrine, and that can reduce the pressure. It may change the blood flow to the ciliary body, and it also increases the outflow. Glaucoma patients with well-controlled pressure still develop neurodegenerative changes. I didn't know this until recently. So if we're controlling the pressure, we're going to slow the progression of damage to vision, but it might still occur. What's interesting is that animal studies have showed that cannabinoid activity in the retina is protective to the optic nerve and decreasing the activation of those resident immune cells. So cannabis and glaucoma, two very separate important mechanisms here. One is decreasing pressure, but the other is protecting the retina from nerve damage, and that's really important. So if you have patients that are well controlled with their drops and they're still using cannabis, I think it's worthwhile to encourage that use if it doesn't have any negative side effects because it's likely going to prevent the progression. Let's talk about cancer. With the exception of cannabis smoke, cannabinoids are anti-carcinogenic. Cannabinoids inhibit tumor growth in multiple cell types. These are the ones that I've found studied so far: breast, prostate, colorectal, adenocarcinoma, skin cancer, leukemia, glioblastoma, lung cancer, uterine cancer, thyroid, pancreatic, cervical carcinoma, oral cancer, biliary tract lymphoma. What researchers love doing is taking some cells from human cancer, injecting them into rodents that are immunosuppressed, and then treating half of them with cannabinoids and not treating the other half, and watching the difference in the growth of these tumor xenografts. I've seen the pictures, they're really incredible. Cannabinoids clearly have anti-carcinogenic effects, and these are through multiple mechanisms of action. Again, cannabinoids, they induce apoptosis, they suppress tumor angiogenesis, they inhibit cancer adhesion and migration, and of course, these, whenever we're looking for substances that can be useful to treat cancers, we're trying to find substances that are toxic to cancer cells, but non-toxic to the rest of our healthy human cells. And that's one reason why cannabinoids are so useful, because they're really non-toxic, but have these strong anti-cancer properties. And I think they make a good adjunct to cancer treatment. One issue is that we don't know anything about dosage for treating cancer in humans, and what we do know from animals, it seems that there's a biphasic effect. So you use a certain amount of cannabinoids, you get this great anti-tumor effect. You use too much, and it starts to diminish, and that probably has something to do with downregulation of our endogenous cannabinoid system. All right, we're going to shift gears again. Thank you for staying with me. Some legal considerations. This is in your syllabus, the Maine DHH website, where you can find the law and hopefully sometime the rules. They still haven't been published for this program. Federal precedent that applies to all of us from 2003, a legal case stated that physicians have a First Amendment right to discuss and recommend medical marijuana with their patients, but not to help them obtain it for medical use. So you can talk about cannabis and whatever else you want to talk about with your patients. Here's the form currently in Maine. This form has to be printed on a tamper-proof certificate, like a full-page prescription paper, and the patient can register with the state for an ID card, but they don't have to. If they have the certificate on them, they're legal to possess up to 2.5 ounces of fully prepared marijuana. They can cultivate 6 flowering female plants for themselves, or they can get their cannabis from a caregiver, which is a grower that supplies up to 5 patients, or from a dispensary. There's 8 dispensaries in Maine that are up and running, and that's the maximum that's allowed currently under law. These are some slides that Gordon Smith from the Maine Medical Association lent me. They're in your syllabus, so I'm just going to skip over them, but it kind of talks about the role of the physician, some legal considerations in recommending cannabis. So if you are going to recommend it to patients, just read through this part here. Certifying minors, there's an extra step, getting a consultation from a state-approved consultant. If any of you are pediatricians and interested at all in providing these consultations, we'd really like that, because the state, the MOA, and the MMA hasn't been able to find someone to help fill this role yet. Physicians cannot prescribe medical marijuana. That includes writing it on a prescription pad. Don't do that. Your prescription pad's just for FDA-approved substances. Physicians cannot assist patients in obtaining marijuana. This includes giving them phone numbers, directions, and so forth. Don't cultivate marijuana and give it to patients. Don't assist patients in using marijuana, and don't recommend it unless you have a good reason to. Qualifying conditions in Maine: cancer, glaucoma, HIV, AIDS, hepatitis C, ALS, Crohn's disease, Alzheimer's, agitation, Neil patella syndrome, which is a rare condition that includes, that usually is associated with glaucoma. I'll get your question in a minute. Intractable pain, which is defined by law as chronic or debilitating disease or medical condition that, maybe I worded this wrong. In the law, it says that it's pain that has been refractory to conventional measures for more than 6 months. So that's what we do when we have someone that comes to us with chronic pain. We look at their records and make sure that they've had at least 6 months of conventional treatment. If they haven't, we make a good treatment plan for them before certifying them for cannabis use. There's also some symptoms that are legal for use in Maine: cachexia, severe nausea, seizures, and severe and persistent muscle spasms. Okay, we had a question in the back.
2 slides back, there's the question about what we cannot do.
Sure.
Assist patients in obtaining marijuana. This includes providing information to patients about dispensaries.
It's silly, but this has been what this is what legal has advised me. You know, if somebody says, you know, how do I get my cannabis after this? I refer them to a public bulletin board that I have in my office. I can't really tell them go here or go there. I can say I've heard from some patients that there's some dispensaries in this area that, you know, that are doing good work. That's it. I just recommend.
Legally, you have to be vague with patients about where they can go.
It's unfortunate, but yes, we have to be vague. But you know, if they have Google, they can, you know, usually find the information they're looking for. Sure.
So when the paperwork goes to the state, does the state then contact the patient?
Almost no patients are registering with the state currently because of privacy concerns. When this law was first passed, it was needed to register with the state. It was required for them to register or pay $100, and that was violating all sorts of HIPAA and privacy issues, so they scratched that. So if they really want the ID card and not just the certificate, they can send in a registration form to the state and get their ID card back in the mail. Correct. A question over there.
Yeah, it's legal by the state, it's illegal federally, so what is our liability, you think, in terms of potential future ramifications of federal?
Good question about the state versus the federal liability, and this will be the last question I answer on legal, and then I can take some after the talk too. As I mentioned before, you're allowed to discuss this with your patients. The federal law still, it's the next slide. So federal law, the Controlled Substance Act still has cannabis as Schedule 1, saying that it has no accepted medical use. And of course, they obstruct research in humans. NIDA seems only to, that's the National Institute for Drug Abuse, only approve studies that are intending to demonstrate the harm in cannabis. So when I go to these research conventions, it's really funny. You have all these people are designing studies to prove harm, and then the benefit is like a little side note that they then, make a big deal out of. But that's just how the system has to work now. So Schedule 1 on the Controlled Substance Act. But look at this federal patent I find really interesting. A patent in the United States by the United States of America, as represented by the Department of Health and Human Services, actually has a patent on cannabinoids as antioxidants and neuroprotectants. So on one hand, they're saying, well, when we can, we're going to make some money off this, and on the other hand, we're going to keep it legal, prohibition and all those other negative effects. So I don't know that federal law is affecting patients in Maine. I haven't heard that yet, or affecting doctors in Maine. But it's something to look out for, and hopefully that will change over time. American Osteopathic Association supports increased research into cannabinoid medicine and rescheduling of cannabis. So does the ACP, so does the AMA, three of the largest physician organizations in the country. There's also this organization of which I'm a member and recently a diplomat, the American Academy of Cannabinoid Medicine, which is promoting standards of clinical practice. What we see in California is that there's so many doctors that for 5 minutes and $40 will just sign your thing, and I don't know how doctors end up prostituting their careers like that. But this was an organization that arose to try to fix that problem and really have high standards in cannabinoid medicine. Quick question.
What does the American Society of Addiction Medicine have to say about it?
The osteopathic version of the American Society of Addiction Medicine came out with their own statement, which was a little more conservative than the AOA. But I'm not sure about the, my guess is that they don't like cannabis. I'm not sure. I'm going to move on. We'll take some questions at the end because I've only got 7 minutes left. And I'd like to present you all with, and I think this is really important, a framework for communicating with your patients about medical cannabis and some of the most important information that you can convey to your patients for harm reduction and for the greatest benefit of use. I think a lot of patients want to talk to their doctors about this, but they're unable to because they're scared, because their providers are biased or judgmental. But just quickly, what I've found is that when I'm the first medical provider that's acknowledged to a patient that something they've been doing illegal might actually be helping their health, they fall in love. There's instant rapport. And after, I mean, this rapport is a clinician's dream. And after that rapport is established, they're making lifestyle changes and, adhering to my treatment plans and following up. And they really have found someone that they can trust. And I want to invite you to explore that with your patients. I think you'll find it very rewarding. The single most important topic is dosage. And this is where a lot of patients go wrong. So briefly, the physiology. When there's persistent cannabinoid agonism, such as high-dose long-term cannabis use, we see that the cannabinoid receptors get internalized into the cell and they become unavailable. So this is the mechanism for building tolerance. It's a decrease in receptor prevalence and maybe also in receptor sensitivity. What's really unusual and wonderful about the cannabinoid system is that it can actually be upregulated with small doses of cannabinoids. So we see that substances like THC and CBD can actually widen their own therapeutic windows in two ways. One, they increase the production of our endogenous cannabinoids, and they also upregulate the expression and sensitivity of the receptors. This is why a lot of people, the first time in their life that they used cannabis, they didn't feel anything, and then the second or third time they finally got the effect, they were priming or upregulating their endocannabinoid system. So what I teach people all the time is how to increase their cannabinoid system sensitivity, where heavy users seem to need a higher dose over time, whereas light users, their dose actually decreases and then plateaus. This is what I guide patients. Use as small of an amount as possible and be patient, expecting that small dosage to actually have stronger effects over time. If someone's building tolerance to cannabis or having withdrawal symptoms, I teach them this resensitization process where they take a 48-hour fast and then they use a much lower doses for 3 days. I have more details about how that works. If somebody's interested, please ask me. But what I all the time find is people come back and say, Doc, wow, 2 joints used to not do for me what 2 puffs is doing right now. So I've really lowered my dosage, saved money, and I'm getting a stronger medicinal effect. So again, I think the complexity of this cannabinoid system has to do with the state of our internal cannabinoid system. And I believe that when people upregulate their endocannabinoid system and sensitize themselves to cannabis, there's other health benefits outside of their direct administration of cannabis. I think it really improves the efficiency of this integral endogenous homeostatic system. Quickly, delivery systems. This was mentioned. Inhaled cannabis is nice because of the fast onset and it's convenient, easy to get the right dose. Of course, smoke and heat and so forth are irritating for the lungs and the respiratory tract. So I don't usually recommend inhaled cannabis via smoking, but vaporizing is actually really nice. You get the same benefits of fast onset, easy dose titration, but no smoke. So basically, the therapeutic properties are in the oil, so you can heat the plant up to a point where the oil vaporizes, but the plant matter doesn't burn. What you end up inhaling is just vaporized oil, not smoke. Cannabis edibles have longer lasting effects due to first pass metabolism. THC becomes 11-hydroxy-THC, which is more psychoactive in most people. It's really hard to consume the right dose, variable absorption. I usually don't recommend this for patients except for those with experience. Sometimes I'll recommend an edible at night because it can help treat their pain while they're sleeping all night long. Tincture is a really nice form of cannabis administration. Faster onset than eating, although still slower than inhaling. Oral mucosal absorption. They can hold the tincture in their mouth. Here's a picture of a pharmaceutical that I'm not promoting, but it's available in Canada in phase 3 trials here in the US. It's called Sativex. It's a whole plant extract with a 1-to-1 ratio of CBD to THC. It's being used for cachexia and MS and cancer pain and all sorts of things in Canada very successfully right now. It's not the only answer, but I think it's a nice product. Cannabis has topical uses, which I mentioned briefly before. I have a lot of patients that rub cannabis cells into their joints or put it on trigger points to help prevent migraine. Totally non-psychoactive, very useful topical cannabis. More and more patients are having good results with it. We've got 2 minutes left and I'm almost done. There's many varieties of cannabis, as you can see here. Some of them have not very medical names. And I'd like to see that change. But in general, the different strains and varieties of cannabis are split into two groups, what's called sativa, which are usually taller plants that have grown closer to the equator. Traditionally, these seem to have more cerebral effects, usually have higher THC, more of a daytime medicine. The indica plants are shorter and bushier, easier for indoor growing. They have more relaxing body type of effects. So the high CBD strains are usually more indica, but nowadays most strains are mixed, each with a unique ratio of cannabinoids, and we really need to get a laboratory up here in Maine to be able to test for both purity and potency and cannabinoid ratios to get this moving forward. I want to acknowledge my deep thanks and appreciation to my mentor in this field, John McPartland, another osteopath with a really interesting career. He has a manual medicine practice. He's an endocannabinoid researcher, and he's a botanist that is well published in hemp cultivation. He's pictured here with Raphael Nahulam, who discovered both THC and the CB1 receptor. This is an excellent review article from Journal of the AOA from 2008. I'd love to direct you to. Not a conflict of interest, but just a disclosure. I am a medical director of 2 integrative practices that evaluate patients for medical cannabis. We also do OMT and other health promoting services. And that's it. Wow, right on time. Thank you all for your patience and your attendance, and I'll accept questions if there's any extra time. Sure.
Are you comfortable, or at least should we be comfortable in authorizing medical marijuana use for people who have conditions that aren't necessarily published by the state? For example, we have a whole list of things that's used for. Are you comfortable authorizing the use for those other medical conditions?
No, sir. So the question is, am I comfortable authorizing medical cannabis use for patients that are not falling under the list of indications published by the state? Certainly not. I can still talk to them about it. They tell me, doctor, that's really helping me with, the biggest example is PTSD. I see so many veterans with PTSD, they come in the office. Those that have comorbid conditions that are approved, we can treat them. But if they don't, I say, look, I believe you that cannabis is helping your PTSD. I'm sorry I can't help you use it legally, but if you feel safe in using it illegally, go right ahead, and here are some modifications for your use that could help you out. Another question over here.
How do you get around the pain contract, either with yourself or with DN specialists that they may be going to? That, you said that this, in Maine, there is no problem, but that is...
No, it's a huge problem, actually. There's large group practices that have practice policies that prohibit the use of cannabinoids concurrently with opioids, which, as you just learned, makes no sense. It actually makes a lot of sense to use them together. If any of you have any control over those policies, I invite you to change them. And if a patient is certified for legal cannabis use, please give them an exemption to that aspect of the pain contract, or make a new contract. Can we do a couple more?
Well, I just want to make it clear. Those of you who want to continue asking questions, please catch Dr. Sulak afterwards. There are some folks who want to catch the next lecture regarding traumatic brain injury and veteran care. So I just wanted to, those who would like to go, it's going to start in just about a minute. If I could have you do one thing for me. First of all, on behalf of the Maine Osteopathic Association, thank you for your time. This is a handmade gift. No. And if you could please draw our hat winner.
All right.
And it's yours. We'll know it's great.
It is 575231.
Anybody?
575231.
Huh?
Okay, we're going to try one more.
Was that yours? Right here. Oh, he got it. Beautiful.
Great. Thank you all. I'll just hang out here for any other questions.
Your hat is waiting right over there.